Hi, my name is James, and today we are talking about normal pressure hydrocephalus, in short, NPH. Yes, it sounds mouthful, but spotting the classic type might even be easier than you think. If you want more quick, practical insights like this, hit subscribe and let's get started. All right, for simplicity's sake, we're just going to call normal pressure hydrocephalus NPH, which usually affects adults over 70. It is actually thought to result from a diminished cerebrospinal fluid absorption and obstruction of cerebrospinal fluid flow. So these 2 points depicted here are believed to initially transiently elevate pressures in the ventricular system. So the name sounds normal, but initially there is actually an elevated pressure in the system until the ventricles enlarge. Now at this time, the pressure normalizes or become nearly normal. The enlargement of the ventricles certainly stretches the paraventricular white matter of the brain, which contains the sacral motor fibers that innervates the urinary bladder and the legs. So it's no secret why gait problems and urinary issues appear, right? Brainstem structures could also be compressed in theory, further contributing to gait abnormalities. Classically, this gives the triad of dementia, gait abnormalities, and urinary incontinence, which is pretty much the textbook version. But here's a twist. In real life, not everyone shows all three, making diagnosis sometimes very tricky. So, when the cause is unknown, we call it idiopathic normal pressure hydrocephalus, but there are also secondary causes like strokes, meningitis, or head trauma, among many others. So NPH is simple on paper, but a bit of a detective case in reality. Well, you might confuse the man on this slide for Mr. Parkinson, but he's not. The classic triad of normal pressure hydrocephalus is dementia, urinary incontinence, and gait abnormalities, easy to remember with the mnemonic DIG. In other words, you need to dig the ventricles for answers. So we're going to start with dementia. Early changes include decline in organization, problem solving, executive function, and attention. Memory impairment usually appears later. Frontal lobe involvement may cause personality changes. The wide-based magnetic gait should help distinguish NPH from Alzheimer's, where severe dementia might look similar. Now, urinary incontinence, typically a late feature. Consider other causes like benign prostatic hyperplasia, pelvic floor disorders, or cystitis. And remember, incontinence alone is not specific to NPH. Gait abnormalities, often the earliest or most common symptom, patients show non-specific imbalance with a magnetic retropulsive stance. Gait may widen over time with slower speed and shorter stride. So, unlike Parkinson's, resting tremor, drooling, and response to L-DOPA are usually absent. Diagnosis of NPH relies on both clinical presentation and neuroimaging findings. The classic standard is usually the triad of symptoms combined with ventricular enlargement disproportionate to cortical atrophy. Let's start with neuroimaging and preferably MRI. We're going to see a ventricular enlargement which is not explained by generalized cortical atrophy, meaning it is not just brain tissue loss that has led to this, but something primarily happening inside the ventricles itself. MRI aqueductal flow voids can also help assess cerebrospinal fluid flow dynamics and paraventricular signal changes. There is something called Evans index, and this is actually the ratio of the maximum width of the frontal horns, which is somewhere here, to the ratio of the maximum internal skull diameter, which is somewhere here. Okay, and this ratio is often increased due to frontal horn rounding. Now, I want to say that ventricular size doesn't always correlate with symptom severity. Additional studies include isotope cystoscopy and cerebral blood flow studies may provide supportive evidence. Now let's take a look at cerebrospinal fluid removal trial. And here, doctors often remove about 30 to 50 mL of CSF, or they may perform a continuous lumbar drainage which removes approximately about 100 to 200 mL within 3 to 5 days, which may improve symptoms, particularly gait disturbance if that is the predominant symptom. Improvement following drainage helps identify patients that are likely to benefit from shunt surgery. And it is important to note that cerebrospinal fluid pressure is typically normal or near normal. Finally, remember not all patients present with a full triad. And again, mild memory or coordination issues in older adults don't automatically mean NPH. And here, clinical judgment is key. So, the mainstay of treatment for NPH is shunt surgery, which helps divert excessive cerebrospinal fluid and relieve symptoms. Ventricular peritoneal shunt, this is the most common procedure where CSF is drained from the ventricles into the peritoneal cavity. Other options include ventricular atrial shunts, CSF drains into the right atrium, and a lumbar peritoneal shunt where CSF is directed from the lumbar spine to the peritoneum. So, modern shunt systems often use differential pressure valves, which open when CSF pressure exceeds a set threshold, for example, when the patient stands upright. Some use programmable valves, allowing non invasive adjustments of CSF flow to fine tune drainage as needed. And importantly, address any underlying secondary cause as part of comprehensive management. Complications of shunt treatment. Like any procedure, shunt surgery for NPH isn't without its risks. The most common complications arise from overdrainage of the cerebrospinal fluid, which can lead to low pressure headaches due to the excessive CSF drainage, and also a subdural hygroma or hematoma from tearing of the bridging veins after rapid ventricular decompression. Fortunately, programmable shunts allow for non invasive adjustments of drainage, reducing this risk and improving long term safety.
Thank you, and I hope this was useful. If you enjoyed it, then hit the like button and subscribe to the channel. Bye.